Welcome back. Today, we are tackling, well, a really significant deep dive. We're digging into Chapter 45 from Porth's Pathophysiology, all about disorders of the female reproductive system. And this chapter it's huge. But what really jumps out is the sheer scope of vulnerability we're going to trace. We aren't just talking localized issues.
No, not at all.
We're looking at how, seemingly simple infections can spiral into infertility, how hormonal balances can shift towards cancer risk, and how everything in the pelvis interacts, think urinary function, GI tract, it's all connected.
That's exactly our goal here, to synthesize those core concepts instead of just listing diseases. We need to focus on the mechanisms, the why behind the symptoms across these major anatomical areas. For you listening, understanding that is the key, not just memorizing facts.
Right, it's about connecting the dots.
Precisely.
Okay.
So let's start externally and work our way in. Hashtag disorders of external genitalia and vagina.
Okay, so the external genitalia, the vulva, it's naturally, pretty susceptible to irritation and infection, right?
It is. Just think about the environment, moisture, secretions. Plus, systemic things like diabetes or kidney disease can manifest there as non-specific vulvitis.
And that vulnerability becomes really clear with the Bartholin gland.
Absolutely. The duct gets blocked, fluid builds up, you get a cyst. Simple enough. But if bacteria get in there, and they often do, things like staph or chlamydia,
It becomes an abscess.
painful.
Incredibly painful.
Yeah.
And a really important clinical point here, age matters. These glands usually shrink after menopause. So a new growth there in a postmenopausal woman, that needs a workup for malignancy, definitely.
Okay, sticking with pain, let's talk vulvodynia. This is chronic vulvar pain, like lasting 3 months or more. And the key thing to stress, I think, is that it's a diagnosis of exclusion.
It absolutely is. You have to rule out infections like candida or herpes, skin conditions like lichen sclerosis, all that, before you land on vulvodynia.
And they're different types, right? Yes, broadly 2 patterns. Localized, where the pain is often provoked maybe by touch or intercourse. And then there's generalized vulvodynia. This is often a more severe, constant, unprovoked pain. It can feel almost neuropathic in nature.
Okay, now let's touch on cancer in this area. Vulvar cancer. It's rare, thankfully.
Only about 3% of female genital cancers, yeah. But what's interesting is how the source breaks down the causes into 2 main pathways.
Right, the HPV-linked one.
Exactly, HPV-associated or UVIN. You tend to see this in younger women, often linked to high-risk HPV like type 16.
And the other pathway.
That's HPV-independent or DVN. This is more common in older postmenopausal women, often with a history of chronic inflammation, specifically lichen sclerosis. So the cause hints at the patient's profile.
Fascinating. Okay, last one for this section, vaginitis. This really highlights the idea of a balanced ecosystem.
It does. Normally, you've got lactobacillus bacteria keeping the vaginal pH really acidic, around 4.0 to 4.5. They do this by metabolizing glycogen.
But if something disrupts that balance, classic example is broad-spectrum antibiotics.
Right, it wipes out the good bacteria, and then opportunistic things like candida, yeast, or trichomonas can take hold.
And we should also mention atrophic vaginitis.
Yes, crucial for postmenopausal women. The drop in estrogen causes the vaginal tissue to thin out, become drier, less elastic, and much more easily irritated or infected. Hashtag tag 2. Disorders of the cervix and uterus. Okay, moving inward now to the cervix. If you want to understand cervical cancer, you absolutely have to understand the transformation zone.
That's the key area, isn't it, where the 2 cell types meet.
Exactly. Think of it as a boundary region, the squamocolumnar junction. The cells there are undergoing change, metaplasia, and that makes them more vulnerable to dysplasia, abnormal changes, especially when exposed to things like HPV.
Which is precisely why the Pap smear scrapes cells from that specific zone.
That's the target.
And the Pap lets us track that slow progression. You might see atypical cells first,
Yeah.
then CIN, cervical intraepithelial neoplasia, grades the first 2, 3.
Which we also classify as low-grade or high-grade squamous intraepithelial lesions, LGSIL or HGSIL.
Right, before it potentially becomes invasive cancer. But the big success story here really is prevention.
Huge success. We know HPV types 16 and 18 cause the vast majority, like 70% of cervical cancers. And the vaccines, Gardasil and Cervarix, have made a massive difference.
Okay, briefly, what about inflammation higher up in the uterus itself?
You can get endometritis, inflammation of the endometrium, the uterine lining. It's often acute, happening after childbirth or an abortion when the cervix isn't acting as such a strong barrier, allowing bacteria to ascend.
Now, two conditions that always cause confusion because they sound similar. Endometriosis versus adenomyosis. Can you break down the core difference?
The absolute key is location. Endometriosis is endometrial tissue glands and stroma found outside the uterus. Ectopic sites.
Like on the ovaries, ligaments, even the bowel.
Exactly. And because it's outside and responds to hormones, it causes inflammation, pain, especially pelvic pain and dysmenorrhea, painful intercourse, and crucially, it leads to adhesions, scar tissue, which is a major cause of infertility.
Okay, so endometriosis is outside the uterus, causing pain and infertility via adhesions. What about adenomyosis?
Adenomyosis is endometrial tissue found within the myometrium, the actual muscle wall of the uterus. This tends to cause the uterus to become enlarged, boggy, globular.
And the main symptoms there?
Heavy, painful periods, menorrhagia and dysmenorrhea, and often painful intercourse, too. But the problem is more contained within the uterus itself, leading primarily to bleeding issues rather than the widespread adhesions of endometriosis.
Got it. That location difference is critical. Now, staying with the uterus, we need to talk about the most common cancer in female pelvis.
Endometrial cancer. Yes, this is number one, and the source is very clear on the main pathway for most cases. About 85% are type 1.
And type 1 is all about estrogen.
It's directly linked to prolonged, unopposed estrogen stimulation. Think of estrogen as the go signal for the endometrium to grow. Progesterone is normally the stop or mature signal if you have estrogen without that progesterone balance.
Like in anovulatory cycles.
Exactly, like with PCOS or obesity, which increases estrogen levels, or taking estrogen therapy without progesterone. That constant go signal leads to endometrial hyperplasia, overgrowth, which increases the risk of atypical cells turning into cancer.
That makes sense. Okay, one more uterine issue. Leiomyomas or fibroids.
Right, these are benign tumors of the uterine smooth muscle, very common.
And their location matters for symptoms.
Definitely. They're classified based on where they are. Intramural in the wall, subserosal on the outside surface, or submucosal just under the lining.
And the submucosal ones are the problem children for bleeding.
Generally, yes. Because they bulge into the uterine cavity, they directly affect the endometrium and are most likely to cause that abnormal uterine bleeding. The good news is they are estrogen dependent and often shrink after menopause. #3, disorders of the fallopian tubes and ovaries.
All right, moving up towards the fallopian tubes and ovaries. And here, that theme of infection causing long-term damage really comes into focus with PID.
Pelvic inflammatory disease. Yes, it's typically a polymicrobial infection, meaning multiple types of bacteria are involved, ascending from the lower genital tract, often started by STIs like gonorrhea or chlamydia.
And the consequences are serious. We're talking chronic pain, adhesions.
Debilitating pelvic adhesions, yes. And critically, infertility. The scarring and damage to the fallopian tubes from PID is a major, major risk factor for being unable to conceive later.
And that damage directly sets the stage for another emergency.
Ectopic pregnancy. Absolutely. This is a true gynecologic emergency. The fertilized egg implants outside the uterus, most often somewhere in the fallopian tube.
Why does it happen there?
Usually because of delayed ovum transport. The egg gets fertilized, but can't make it to the uterus properly because the tube is damaged, scarred, or kinked, often from previous PID or maybe tubal surgery.
And the symptoms can be severe.
Yes. Pain spotting are common, but if it ruptures, you get internal bleeding, which can cause severe abdominal pain, possibly referred shoulder pain from diaphragmatic irritation, even fainting or shock, life-threatening.
Okay. Now, on the ovaries themselves, cysts are pretty common, right?
Very common. Most are benign functional cysts, follicular cysts, or corpus luteum cysts related to the normal menstrual cycle. Usually they cause no symptoms and resolve on their own.
But they can cause problems.
They can. If they rupture, they can spill fluid and cause sudden sharp pain. Or sometimes a larger cyst can cause the ovary to twist on its supporting ligaments. That's ovarian torsion. Another surgical emergency causing severe pain due to loss of blood flow.
Now for a major functional disorder. Polycystic Ovary Syndrome, or PCOS.
Right. PCOS is complex. Diagnosis usually needs at least 2 out of 3 criteria. Infrequent periods or no ovulation, oligomenorrhea ovulation, clinical or biochemical signs of hyperandrogenism, excess androgens.
Like hirsutism or acne.
Exactly. And polycystic appearing ovaries on ultrasound.
What's the underlying mechanism here? It's hormonal, right?
It's primarily hormonal, yes. There's often an imbalance with elevated LH, luteinizing hormone, relative to FSH, follicle-stimulating hormone. This pushes the ovaries to produce more androgens, which interferes with normal follicle development, so you don't get mature eggs released, hence the anovulation and cysts.
And PCOS isn't just about fertility, is it? There are bigger metabolic implications.
Huge implications. A key feature is often hyperinsulinemia and insulin resistance. The body doesn't respond properly to insulin, so it produces more. This contributes to the hyperandrogenism and also puts these individuals at much higher long-term risk for type 2 diabetes, cardiovascular disease, and metabolic syndrome.
That's critical to remember. Okay, finally in this section, ovarian cancer.
A really challenging one. It's often called the silent killer because the symptoms are so vague, especially early on.
Like bloating, abdominal discomfort, feeling full quickly.
Things that are easily dismissed or attributed to other causes. This leads to diagnosis often at a late stage when it's much harder to treat effectively. And unfortunately, we don't have a great screening test for the general population.
What's the biggest risk factor the source points to?
The most significant one is often considered ovulatory age. Basically, the total length of time in a woman's life that her ovulation isn't suppressed.
So fewer pregnancies, less time breastfeeding, not using oral contraceptives, all those increase the cumulative number of ovulatory cycles.
Exactly. Each ovulation involves rupture and repair of the ovarian surface, and the theory is that this repeated process increases the chances for malignant transformation over time. Hashtag 10 of few, disorders of pelvic support, and menstrual disorder.
Okay, let's shift gears a bit and talk structure. Pelvic support. This is where anatomy, gravity, and maybe childbirth history come into play.
Right. The uterus, bladder, and rectum are held in place by a complex network of ligaments and the muscles of the pelvic floor, the pelvic diaphragm.
Yeah.
When these supports weaken, often due to the strain of childbirth or simply aging and loss of estrogen.
Things start to descend.
Prolapse.
Exactly. And we name the prolapse based on what's bulging into the vagina. The source has a helpful figure 4511, showing this. So if the bladder herniates posteriorly into the vagina,
that's a cystocele. And it typically causes urinary symptoms, difficulty starting urination, feeling like you can't empty completely, maybe stress incontinence.
And if the rectum bulges forward into the posterior vagina,
that's a rectocele. This leads to difficulty with bowel movements. Patients might feel like they need to manually splint or push on the back wall of the vagina to have a bowel movement.
And then the uterus itself can prolapse down into the vagina.
Yes, uterine prolapse. It's graded based on how far down it descends, from mild descent to procedentia, where the entire uterus is outside the vaginal opening.
Okay. Now let's swing back to function and talk about menstrual cycle problems, specifically abnormal uterine bleeding, AUB.
AUB is a broad term. To make sense of it, clinicians often use the Polycystic classification system. It's a mnemonic that helps organize the potential causes.
Right. Pylons for structural things you can usually see.
Exactly. P for polyps, A for adenomyosis, L for leiomyomas, fibroids, M for malignancy or hyperplasia, structural causes.
And choeine is for the non-structural stuff.
Correct. C for coagulopathy, bleeding disorders, O for ovulatory dysfunction like PCOS or thyroid issues, E for endometrial causes like inflammation, I for iatrogenic, caused by medications or devices like IUDs, and N for not yet classified. It's a systematic way to think through the possibilities.
And often, the underlying issue in ovulatory dysfunction comes back to hormones.
Very often. You can have bleeding from estrogen deprivation, like the drop before a normal period, but if it happens irregularly, the lining breaks down sporadically. Or, very commonly, bleeding happens because of a lack of progesterone.
That an ovulatory cycle again.
Yes. No ovulation means no corpus luteum, which means no progesterone surge. Without progesterone to stabilize and mature the endometrium that estrogen built up, the lining gets thick, unstable, and eventually sheds incompletely and unpredictably, often leading to heavy bleeding.
Makes sense. What about painful periods, dysmenorrhea?
We need to differentiate primary from secondary. Primary dysmenorrhea is the common type, usually starting in adolescence. There's no underlying pelvic pathology. The pain is thought to be caused by excessive release of prostaglandins from the endometrium, causing strong uterine contractions and cramping.
And secondary?
Secondary dysmenorrhea is caused by an underlying structural problem or disease process. Things like endometriosis, adenomyosis, PID, fibroids. It often starts later in life, maybe in someone who previously didn't have painful periods. The pain pattern might also be different.
Okay. Lastly, in this group, premenstrual symptom disorders. PMS in its more severe form, BMDD.
Right. This spectrum ranges from mild premenstrual syndrome, PMS, to the really debilitating premenstrual dysphoric disorder, PMDD, which has significant mood symptoms. The exact cause is still, well, a bit unclear.
It's not just abnormal hormone levels, though.
No, it seems to be more about an abnormal response in the central nervous system to the normal fluctuations of estrogen and progesterone during the luteal phase. There's likely an interaction with neurotransmitters, particularly serotonin seems to play a key role, which is why SSRIs can be effective treatments. #V, disorders of the breast and infertility. All right, moving to our final section, starting with the breast, let's quickly cover a few benign conditions mentioned.
Okay.
There's mastitis, which is inflammation of the breast tissue, often happens during lactation, usually due to a bacterial infection, commonly staph, ascending through the nipple ducts.
And galactorrhea.
That's inappropriate milk secretion, producing milk when not pregnant or breastfeeding. This signals a need to check prolactin levels, as it could be caused by hyperprolactinemia, maybe from a pituitary adenoma, a prolactinoma,
And those common benign lumps.
fibroadenomas. These are very common benign solid tumors. Classically feel firm, rubbery, well-defined, and importantly, they're usually freely movable within the breast tissue. Classic benign finding.
But then, of course, we have breast cancer. Still a major health concern, the second leading cause of cancer death in women.
It is, and risk factors are numerous, being female and increasing age are the biggest. But also hormonal factors play a role, early menarche, late menopause, nulliparity, no pregnancies basically, longer lifetime exposure to estrogen. And genetics, of course, like the BRCA1 and BRCA2 gene mutations.
Detection relies heavily on screening.
Yes, primarily mammography. It's amazing it can detect lesions down to about 1 millimeter, often long before they can be felt. This is combined with clinical breast exams and, importantly, breast self-awareness, knowing what's normal for you.
And once a cancer is diagnosed.
Diagnosis and staging are critical: tumor size, lymph node involvement, metastasis, T&M staging. But for guiding treatment, especially hormonal therapy, assessing the tumor's receptor status is vital.
Estrogen receptor, ER, and progesterone receptor, PR status.
Exactly. If the cancer cells have these receptors, it means estrogen is likely driving their growth. That opens the door for targeted hormonal therapies like tamoxifen, which blocks estrogen receptors, or aromatase inhibitors, which reduce estrogen production in postmenopausal women. It tailors the treatment.
Okay, let's wrap up with infertility. How is it defined?
Generally, it's defined as the inability to conceive after 1 year of regular, unprotected intercourse, or 6 months if the woman is over 35.
And when investigating the cause, it's important to look at both partners.
Absolutely. It's roughly a balance. About 1/3 of cases are primarily due to male factors, issues with sperm count, motility, or morphology, which we assess with the semen analysis. And about 1/3 are primarily female factors. The rest are combined or unexplained.
So focusing on those female factors, what are the key areas?
There are several major categories. One is diminished ovarian reserve, DOR, basically, having fewer eggs or eggs of lower quality than expected for age. We can get clues from hormone levels like FSH, estradiol, and especially AMH, anti-Müllerian hormone.
Ovulation problems are another big one.
Yes, ovulatory dysfunction. This could be due to PCOS, as we discussed, or thyroid problems, hyperprolactinemia, hypothalamic issues, anything disrupting that regular release of an egg.
And then we come back to the tubes.
We do. Tubal factors are critical. Damage or blockage of the fallopian tubes prevents the egg and sperm from meeting or the fertilized embryo from reaching the uterus. And the most common cause of that damage?
PID again.
Often, yes. Scarring and adhesions from past pelvic inflammatory disease. It really underscores that theme of how infection can have such profound, long-lasting consequences on fertility.
Which highlights why treatments like Assisted Reproductive Technology, RT,
like IVF and vitro fertilization, become necessary for many couples facing these issues, especially tubal factor infertility. IVF bypasses the tubes entirely. #tag outro.
Wow. Okay, that was an incredibly dense but really important journey through Chapter 45. We went from localized issues like vulvar pain and Bartholin cysts,
Right through hormonal complexities like unopposed estrogen driving endometrial cancer, or the hyperandrogenism and insulin resistance in PCOS.
connected structural problems like prolapse and fibroids to symptoms, and kept seeing how infection like PID can lead to devastating consequences like ectopic pregnancy and infertility.
I think that interconnectedness is the absolute key takeaway, how one problem often leads directly to the next. That chain reaction, especially infection leading to scarring, leading to infertility or ectopic risk, seeing those links is crucial for really understanding this material.
It really is vital knowledge. Thank you for sticking with us through all of that complex, high-yield information.
Absolutely. And maybe something to think about further, as our understanding of hormonal signaling gets more and more precise, estrogen pathways, progesterone's role, insulin's impact, how might that allow for future preventative strategies?
You mean moving beyond just managing symptoms?
Exactly. Could we eventually target the root molecular causes of conditions like type 1 endometrial cancer or even PCOS, maybe preventing them before they fully develop? It's looking towards a future of more targeted preventative care.
That's a really powerful thought and definitely points to where the future of this field might be heading. Until next time, keep exploring the fascinating world of pathophysiology.